And now I'm going to introduce Dr. Alton Russell as our next moderator. Dr. Russell is an assistant professor at the School of Population and Global Health at McGill here. He is a decision scientist. I'm curious of what that means, and I'm looking forward to hearing, who uses data-driven modeling to inform the efficient and effective use of finite healthcare resources. So very cool. He employs decision analytic modeling, simulation, optimization, and data analytics to improve health policy and clinical decision-making. His research has contributed to decisions in blood banking and transfusion medicine, reducing harms from opioid use disorder and other clinical areas. So I'd like to welcome Dr. Russell up to the front. You can take it over from here.
Thank you, Dr. Gommerman. So I'm going to be a moderator as well as a panelist. I'm the only in-person presenter here, so I know that those online can't see the clock. Since we have 4 presentations in this session, I'll ask those joining us presenting online to do their best to keep to 8 minutes. I'll introduce my 3 other panelists now, and then I'll get into my presentation. So Dr. Dawn Bowdish is joining us online, and she's a professor of medicine at McMaster University and the Canada Research Chair in Aging and Immunity, as well as the Executive Director of the Firestone Institute of Respiratory Health. Dr. Bowdish and her research team investigate what makes older adults vulnerable to pneumonia and COVID-19, how age-associated inflammation and the microbiome impact healthy aging, and how our response to vaccines changes with age. And by understanding the aging immune system, she hopes to protect older adults from infection and improve their immune systems. And she also sits on the board of directors of the Lung Health Foundation. We're also lucky to have someone who's already been mentioned today, Dr. Deborah Money. As many of you heard yesterday, she is the Executive Vice Dean of the Faculty of Medicine and the head of the Department of Obstetrics and Gynecology at UBC. And she is also the Executive Director and the Director of the BC Women's Hospital and Health Center. During the COVID-19 pandemic, Dr. Money led CanCOV-PREG, which is a national Canadian surveillance program of COVID-19 in pregnancy, and a serosurveillance program that uses residual sera from antenatal care. And last but not least, we have Scott McLeish, who is Assistant Director in the Center for Direct Health Measures at Statistics Canada. He oversees a range of health statistics programs that combine physical and laboratory measures of health with self-reported information, and recently this includes the Canadian COVID-19 Antibody and Health Survey. And prior to his current role, Scott held various positions over almost 20 years at Statistics Canada, which covered a range of topics from mortality to immigration statistics. So very happy to have my fellow panelists joining us remotely. And yeah, so I'll turn to my presentation now. Yes, I should have slides. So while those are being brought up, I can give a little more context. I'm a relative newcomer to Canada and to serology research, although I've worked with blood banks for the last few years. And it's been very different than my typical work here. Looking at, one of the main focuses has been looking at the representativeness of different types of serological surveys, and been very fortunate to have a research program in that area. So we'll talk about some of the considerations around residual blood surveillance and share some of our results trying to look at the representativeness. So hopefully my slides will be coming up soon. Sure, I can go ahead and kind of get started. So there are, great, perfect, thank you. So here are my slides. To start off, I wanted to just kind of mention how many different dimensions there are of seropositivity. So on the slide that should be coming up soon, if I keep pushing the green button, there are just a lot of different dimensions, right? And we think about age and sex, oftentimes we think about health and comorbidity and other times. But anyway, I just spent a few minutes trying to list all of the different dimensions that are relevant for different pathogens and different policy questions, and I'm sure I missed several. This is, I think, obvious to a lot of us in the room, but residual blood, like representativeness of a cohort is specific to the pathogen you're looking at and the policy question even within the same pathogen. So, we could have residual sera for a sexual health clinic that serves largely men who have sex with men and trans individuals. We've got blood donors, we've got pediatric emergency data, which the Colonel's popcorn study looks at. And this isn't probably the right matching of pathogens to cohort. Maybe something like this would make more sense. So representativeness is not just a characteristic of a residual blood program or any kind of study population. It's specific to the question. What matters is specific to the question. And we've done some work comparing the representativeness of different studies. So Matthew Knight, a master's student who's in the room with us, has largely led this work. And we've got 2 residual blood sera in this study, which is the Alberta Precision Lab outpatient samples and Canadian Blood Services. We're comparing it right now to 3 other cohort studies. 2 were pre-existing the pandemic, the longitudinal study on aging, and then CanPath, but then they added a COVID serology component. And then the ABC was based on a marketing study. We're also going to have the SATS Canada's CCAS study in here. We just need to get the data out of the RDC, which we're working on. So I don't have those data. And what we did is we looked across different stratifying by different characteristics. What is the representativeness of a strata in the study compared to the target population, and for this we based on census data. And based on that ratio, we classified the strata as being over or underrepresented. And here's some preliminary results. So we've got the blood donors and the outpatient labs on the left, the other studies on the right. And stratifying by male, female sex, and urban, rural, we see that the top row, all of those numbers are less than 1, meaning that we have fewer rural people than urban people based on their zip code, or postal code across studies. But particularly, actually, the residual blood did a bit better than some of these other studies. And we can also look at it by racialized minority, which is something that we don't typically have in administrative data except for blood donors, because race has to do with kind of your likelihood of having a rare blood type. We do collect those data in blood donors. So we can see that actually the blood donors did better, particularly with male representation from racialized minorities. And we can also look at people's postal code and look at their neighborhood level of material deprivation quintile. We've only been able to do this so far for the donors and the outpatient labs, though we will have it hopefully coming out of the research data center soon for the CCAS study. And we see that actually the outpatient labs are quite representative, which makes sense. With the blood donors, they do tend to come from less material deprived neighborhoods. So we do have a little bit less representation of those most materially deprived neighborhoods. And I'm not going to go into detail of this, but we can do this by all kinds of dimension. We can stratify by age. So you can kind of see that within these categories, some are better or worse on different age strata. But just who's represented isn't the whole picture. If we have enough samples, then even from a strata of the population that's less represented, we can do statistical adjustments. And just because the residual blood studies, like the CBS and APL, were so much larger, because they didn't have to build up this de novo infrastructure and recruitment plan, they were able to test so much more samples more efficiently. And this is kind of showing if we try and stratify the population by age group, sex, province, month, and then add finer and finer stratification, we've got more strata with a sufficient sample size. We just chose 25 somewhat arbitrarily to do these statistical adjustments. So I think that's another important consideration. It's not just like the ratio of people in the group, but if you've got a big enough group, you can do these adjustments that can improve the representativeness of your estimates, even if the population itself is less representative. Another work, I'm not going to present any data from this because of time, but we wanted to look at statistical adjustment for representativeness. And we had this hypothesis that if the representativeness of the population is the main driver or a key driver of why the outcomes of serological cohort studies differ, then adjusting for it correctly will bring seropositivity estimates closer together. And we thought that the the fanciest method, which we use Bayesian multi-level regressions post-stratification, was going to bring these estimates across cities closer together. And we actually found that adjusting for the variables we have, which were age, sex, race, urbanicity, did not consistently increase the concordance of the seropositivity estimates. So I think this suggests that in the case of COVID-19, where it's a novel infection that affected kind of the whole population, the representativeness of the cohorts wasn't the main thing that was driving why one study says this is the value, another study says something else is the value. I think that it could be that there are unmeasured dimensions of population differences that we didn't adjust for because it's not captured. But I think more likely it's really that there's other differences in the assays used, what's happening in the laboratory, whether you're doing a dried blood or venous, the timing of sample collection versus analysis. These things, it's hard to disambiguate, but it seems like they're driving these differences more so than the population representativeness in the case of COVID serology, which might not apply to other pathogens. If we want to look beyond the dimensions I've shown, we can use neighborhood level indicators by mapping postal codes. If we administer questionnaires, we can get a whole lot more data elements across which we can assess or adjust for representativeness, look for health disparities. And linking to administrative data is a very powerful tool. The challenge, of course, is the more data elements you have on each individual, the greater the privacy concerns. And I think that stakeholders and legal versus the researchers are not always aligned in kind of what's the right balance between privacy consent and versus the real value of having these data elements. One of the things we've been working to do for a while now is to link the residual blood cohorts, first Canadian Blood Services with ICES, which Sheila talked about a little bit, and then the outpatient lab data with Alberta Health Services data on administrative healthcare data. Sheila talked about this in the concept of getting their vaccine data, but another benefit is to look at representativeness because we can compare rates of diabetes, people who have claims for long-term disability, et cetera, and see we can characterize and potentially adjust for these other elements of representativeness that matter. The challenge is that this has taken a very, very long time. If we wanted to be able to do this real time to inform decisions while a pandemic is going on, a lot of walls and roadblocks would need to be overcome. Multimodal data synthesis is another potential way to overcome the fact that each cohort has its own biases. Federated approaches to modeling is something that we've been working on a little bit to try and address this. The challenge when it comes to, at least for the COVID serology data, is that there are these differences other than representativeness that drive differences between these studies that my lab at least doesn't fully understand, and we're having a hard time teasing those out and adjusting for them. So I think that if we want to combine data across different cohorts, different labs, I think that is a great goal, but we need to figure out how to handle these different sources of biases that go beyond just representativeness. So the take-home message is representativeness is not a unique challenge to residual blood studies. In some ways, they have advantages because there's not that self-selection in. And certain residual blood streams are certainly well-suited, probably better suited than probabilistically sampled surveys for certain policy questions. Population sampled, differences in the population samples is not seem to be the main reason why different studies had slightly different findings in the case of COVID-19. And we can only account for the variables that are in the data set. So capturing race and ethnicity and administrative healthcare data beyond the blood donors is something I think we should try to do. Finding ways to administer questionnaires or contact the people whose residual sera we're analyzing is something that can help us get more context and better characterize the population. And timely linkage to administrative data are all things that we could use to get more value out of the data, identify health disparities, and understand the representativeness of our cohort. So thank you very much for listening. This is my team I'd like to recognize. Thank you. All right, so I'll turn it over to Dr. Dawn Bowdish now.
Hello. Can you hear me okay?
We can.
And great, thank you. I'll share my screen. And you can see the screen, I hope.
It's coming up. I can see it on my monitor, and I think it's coming up on the the big
Okay,
monitor.
great. It's a bit slow on my own. Okay, hello. I've been so pleased to be able to participate virtually with you through this meeting. As those of you who know me know, I'm really passionate about the lives of older adults, and cherishing older adults begins in the home. I couldn't join you because I had to be at my mother's 70th birthday party last night, but I will bring her good wishes to you in the form of this talk as well. So I'm going to tell you a little bit about our experience with serosurveillance using in our COVID and long-term care study. And this was a study that had 26 different long-term care and retirement homes across the province of Ontario. There was a mix of for-profit, not-for-profit, and community-run homes. So there was a huge range of homes, a huge range of infection experiences, a huge range of different infection rates in the different homes. And my slides don't like me very much today. Okay.
Yeah, can we have the slides are showing there be the same as the slides that are showing on my monitor instead of?
Is it?
It is in presentation on this monitor, just not on that one.
Okay, let me try something like that. Does that look better?
Yes, perfect, thanks.
Okay, thank you. So this is what COVID hospitalizations look like for older adults. And our study was started right during the first 2 doses. And we were able to capture serum samples from about 1,500 participants roughly every 3 months. There was a lot of turnover in the long-term care and retirement sector, but overall, we were able to assess over 1,000 different specimens for sero conversion. And that's the data I'm going to show you today. One of the things that we were really lucky about in working with this population is in the province of Ontario, the bar for PCR testing was really low for the big part of our study. So we had surveillance testing when people were getting PCRs just randomly to see how much COVID there was in their home. We had symptom testing with a very low bar for testing. Fortunately, the managers of the home and the policymakers realized that older adults and frail older adults often don't display the same symptoms as young adults. So especially in the pre-Omicron era, often GI symptoms were a really common symptom that people had, and that wouldn't have been a bar for testing for influenza-like illnesses. So for a big part of our study, the bar for testing was really low. It could be a headache, it could be any symptom whatsoever. And importantly, the people who were employed in our home in our study were actually the caregivers of the staff. So they were really empowered to do lots of testing if they had any concerns about the health of the residents. We also had contact testing. So if someone's caregiver or a roommate or someone who they shared a shared service with had COVID, there was lots of contact testing as well. And only at the very late stage of our study did we shift into only having testing that hit the criteria for like influenza-like illness. And consequently, we really do feel like we've caught the majority of the infections. There was very little seroconversion that we didn't have a rapid antigen test or a PCR test to go along with. And so these were really valuable data to collect because older adults don't always seroconvert at the same rate, especially in the Omicron era. And it allowed us to, because there were just so many infections, to look at the rates of seroconversion to anti-N antibodies. One of the reasons I think this population is so important to continue serological testing and so unlikely to have anyone continue in this testing is because the rates of infection are still incredibly high. On the bottom, what you're looking at are the hazard ratios of whether or not having had a previous infection protects you from a future infection. And what we found is that unlike the general population, where in general you get some protection, even if it's fleeting from an original infection, for many of our participants and for many of the variants, that wasn't really the case. And when the study began, the thought in the policy sphere was, yes, there was this terrible tragedy of deaths and infections in long-term care, but once all these people were infected, then, we'd have sort of only the survivors or they'd have some sort of protection. And that just hasn't panned out to be the case. So I think it's important for us to continue to understand how these infections are influencing the homes. And I'll show you a slide at the very end of the talk that speaks to that. So as I was hoping to hear in the context of this panel discussion, or what we've heard in the last 3 days, that someone has found something better than nucleocapsid to do seroconversion. And my sense is we are all working with a fundamentally problematic antigen to try to ascertain the difference between infection-induced and vaccination-induced. When we take all of our participants and we look for anti-nucleocapsid antibodies, either IgG or IgA, you can see that the seroreversion rate rather, is pretty short in this population. So we only really have 248 days for IgG when things, people serorevert. However, what I would like to do is break this down by variant and show you that the accuracy of these measures is probably not very high in the Omicron era. So on the top here, we're looking at 3 different sets of infections, IgGs in the gray and IgAs in the mauve. And in the pre-Omicron era, you could actually see that people who survived their gamma or delta infections actually maintained these anti-nucleocapsid antibodies for a reasonably long period of time. But you'll see, and this trend will be exaggerated once we hit the Omicron era, that the rate of seroreversion was much faster. And in fact, we saw more people didn't seroconvert at all to anti-N antibodies. And then, so on the top again, now we're looking at BA5, BQ, and the XBB, which was around the time our study was ending. So we don't have very many data points for XBB. But again, you can see that the seroreversion rate's pretty steep in these Omicron era time periods. Now, if we look in contrast at vaccine-induced immunity, we see that we almost have 100% seroconversion for anti-spike. We have reasonably high levels for IgG. But again, if you look at the nucleocapsid, you see that those rates are fairly low. And so my concern is that in this population, when we have in this particular time frame such great documentation of actual infections, that we need to really think about serially sampling and being aware of sort of the time points of seroreversion to make accurate guesses about infection rates. The data right now from everyone's favorite slide is that older adults, about 7 in 10 of them may not have had an infection as of yet. And because we know people's first infection is the most severe, it's important to know that we're still facing a pretty strong and potent public health concern for these people who have not yet been infected. But I want to use this as an opportunity, and in fact, to use every opportunity I have for the rest of my career, to point out that COVID is the #1 public health concern in the long-term care and retirement sector. Even pre-pandemic, Canada had the highest rate of infectious disease deaths in long-term care of any OECD country, and we beat that record in the COVID pandemic. And when you look at the rates of COVID outbreaks in the long-term care and retirement sector, they dwarf our pre-pandemic rates by an order of magnitude. So we need to continue really targeting and advocating for this extremely vulnerable population. After SARS-1, there were a series of recommendations about protecting the long-term care sector, none of which were implemented. And in the province of Ontario, none have been meaningfully implemented in the context of COVID-19. So I beg and plead with you all to continue advocating and thinking about these very vulnerable populations, because I can tell you these continued outbreaks do affect the rest of their care and certainly affect quality of life. So I will leave that with acknowledging the members of our team who collected all these data and worked with all the participants. And as always, I want to leave the last word with the people who we do this for, the residents of long-term care and retirement communities. Thank you for your attention.
Thank you, Dr. Bowdish. I hope people are making notes of questions. We'll try and leave time for that at the end, and I'll move over to Dr. Deb Money. Thanks.
Hello, everybody. Pleased to be here. And again, sorry that I'm not there with you in person. Can you see my slides?
We can, not in presentation mode yet, but we...
Yeah, I'm just getting there, sorry. Okay. So I will try and keep it brief today. Just wanted to talk a little bit about the representation of antenatal sampling as an opportunity for, I'm just adjusting my view here. So we, as many of you know, conducted a national surveillance study that utilized the residual antenatal bloods to assess SARS-CoV-2 seroprevalence. And we'd really hope to leverage this data to gain insight into the entire adult population. And, whoops. So I spoke about this on Wednesday, but just to recap that pregnant women throughout the entire population are offered routine prenatal serology that's run mostly in central labs for infectious serology. Many of these samples are stored, but in some provinces that sampling is distributed, so prenatal genetic marker testing has is available as a secondary option. The samples these days are taken usually more than one time because of the syphilis problem. And so there's up to 2 to 3 samples per pregnancy taken for syphilis screening. So that presents even another opportunity. So when we think about representativeness, people think, well, they're just pregnant people, but in fact, overall, we have about 1 to 1.5% of women in the 15 to 49 age bracket who are pregnant in a given year. Now, this is actually quite low because we're a low fertility rate country compared to 4% or more in low and middle income countries. But it is still a broad-based representation, but is age limited, of course, with the bulk being 30 to 34, but the range across that fairly large multi-decade age range. I think the question that we can't entirely answer perfectly, are pregnant women totally representative of females of that comparable age? There's probably some specificity to those who become pregnant versus those that don't at a given time, but it is still a common phenomenon for women in reproductive age. And then we've got a situation where you have to believe that women's seroprevalence is representative of both sexes. What is useful and I think helpful is that pregnancy is a bit ubiquitous across all regions, across all socioeconomic classes, across all ethnicities and race, and urban and rural representation. So that piece is a bit unique compared to many of the other serosampling opportunities we have through, for example, Canadian Blood Services, where it's a bit more urban and there's certain characteristics to people who volunteer to give blood. And there is a rather uniform uptake within this population, so there isn't a sort of entry into study bias if we're using residual samples. But it is absolute that they are not necessarily representative of the younger and older age cohorts. This is just an illustration of the kind of data that we were able to see with the very low seroprevalence, but not zero back in February of 2020, and then the significant uptick in that first year of the pandemic. We see a representation way back in the early phase that shows these little blue markings show seropositive samples that are scattered all over, although concentrated in urban areas. And this is in a context where not every province was able to participate. And then we were also able to show, as many other studies have done, was that the large uptick between the end of 2021 and early 2022. And when you carry on with the sampling that we continue to do through 2024 with our colleagues at the BC CDC, we're seeing that this is a constant since that time, pretty steady, in fact, in this age group. So, really, my bias is that antenatal serosurveillance gives us an opportunity of a relatively unbiased set of samples with regards to geography, ethnicity, and socioeconomic status, because of the ability of pregnancy to represent that diversity in the population, with the limitations of sex specificity and age specificity. But I think it's certainly a piece in a large puzzle that I think can help when we have different sources of residual blood sampling. And despite the very, very challenging circumstances that we talked a little bit about the other day, we were able to capture a representative picture and capture some of the information because of historic samples from the very early phase of the pandemic right the way through. And timeliness of data sharing was, of course, a real limitation. But the hope would be with HemaNet that this could be set up ahead of time and these assets could be used better in a future situation. So I'll stop there and happy to take questions at the end.
Thank you very much, Dr. Money, and we'll move right along to Dr. Scott McLeish.
Not Dr. Scott McLeish. I'll just try to share my screen. Apologies. Can people see my screen?
We can, yep, not yet presentation mode, but we see PowerPoint. Yeah. Your clicks are very loud on our end. That's why people are laughing in the room.
Is it? Oh, okay. Apologies. Heavy finger, I guess. Okay. So thanks a lot for having me. I'll start by saying that some of these are my favorite topics as a statistician. Uncertainty, sampling, representativeness, measurement. So I'm really happy to be here, and I'll try my best to keep my part to the 8 minutes. I'm going to be speaking really from our experience in terms of the COVID-19 response that we had, and a little bit of the CCAT study that we had before. But I'll start by just giving a bit of an overview of Statistics Canada and the role that we could play in this type of area. So first of all, one of the things that we have that is quite powerful, that is a bit different than from the other studies that have been described, is that we have access to really comprehensive and high quality frames. So what that means is that we're in a position where we can draw fairly accurate samples that are representative of the population and be able to conduct surveys on that. And we do that across all domains. The census was mentioned before, but of course we have the labor force survey and other things as well. Attached to that is we have extensive data collection and methodological infrastructure that's already in place. We have years of experience collecting health surveys, including the Canadian Health Measures Survey as well. One of the other things that we're able to do, and it was talked about in one of the earlier sessions as well, is we're able to do lots of linkage work. We have an entire environment that's set up at StatCan to be able to facilitate linkages between different data sources. And this really allows an ability to get a disaggregation of results using other sources like the census to be able to add attributes and characteristics to files that might not otherwise have collected that information. I'm going to speak mostly from our experience associated with the Canadian COVID-19 Antibody and Health Survey. This was something that we had 2 cycles that were developed in partnership with the Public Health Agency of Canada and CITF. But I'm going to focus most of my discussion around the second cycle of that survey. This was a survey that was initially intended to provide a national representative study on long-term symptoms of COVID-19, and it was the beginning really designed to be a self-reported survey only. But in partnership with FAC and CITF, we very quickly expanded the objectives of this. So we included a dry blood spot collection as well as a saliva collection element. And so this was really intended and designed to be able to see that we can provide representative and disaggregated benchmarks related to those measures, and also understand how a wide-scale survey-based methodology could be used to inform the space as well. So I'm just another quick shout out to our partners that really facilitated that. And I know there was a lot of discussion in one of the earlier sessions this morning about the range of expertise. And as you can kind of tell from my own background, I don't have this background in epidemiology or in serology or virology. So it's been really critical for us in this partnership to really lean on each other's levels of expertise in different fields. So the survey design itself, so we started, as I said, we had a very representative frame of households across Canada. This survey in particular was designed for collection in the 10 provinces and really focusing on private dwellings. We had a sample size of about 100,000 households that were selected, and we really focused on the population 18 and plus for this particular survey. We did our collection over 3 waves through the spring of 2022. So there was a various ranges of these components. So unlike some of the other studies where participants were effectively coming in and having a direct interaction, this was a household-based study. So we actually would mail out kits to those 100,000 households, inviting them to participate. There was a questionnaire component that was electronic that was available online. But we also had a kit for them to provide dry blood spot samples as well as saliva samples. What would happen is once they completed their survey, they would ship those things back. We had a pre-packaged envelope for that purpose. That was then sent to the lab for analysis. Those analytical results from the lab were then integrated with their electronic questionnaire responses at StackHand and then released. And then the biospecimens themselves, they ended up being placed in our StackHand biobank that's at the National Microbiology Lab. Our questionnaire covered a range of different topics. So we had information about their pre-existing health conditions, long-term symptoms, et cetera. Also things that were directly related to SARS-CoV-2, so their experience with first infection, how they may have tested positive, symptoms, et cetera. As I mentioned before, the original purpose was really understanding the long-term symptoms, so that was a very important module of the survey as well. There was information in vaccine history, as well as access to care during the pandemic, and a range of socioeconomic characteristics. As I mentioned earlier, we are able to integrate with other sources. So we had some socioeconomic characteristics that were collected directly on the survey, but for some other things, we actually linked to other data sources and then brought the information that way. There was a range of different components to the survey beyond kind of that original purpose. And I was glad that it was raised a couple of times. One of the challenges that we had was really on the measurement side. So we did work closely with our reference labs and the National Microbiology Lab to work on some different approaches to estimating seroprevalence, especially with increased uncertainty in NTN when we were in the field in spring of 2022. This was also, as intended, provided really the first major national representative study on the prevalence and characteristics of those Canadians that were living with long-term symptoms following COVID-19. That was then followed up. This is a survey that we followed up 12 months later, approximately, with an additional questionnaire to really look at long-term outcomes for those individuals as well. We had the saliva sampling, which was PCR tested on that random sample of Canadians, and then there was RNA sequencing that was performed on the positive test results as well. And as I mentioned before, we really leveraged existing data sources to be able to add to the social determinants of health, both at the individual level and area-based level as well. So from our perspective, there's some keys here to consider, I think, from a representative study. So one is that this wasn't a sample that was restricted to those interacting with a specific component of the system. It was really that we drew our own sample of a frame of households in Canada. Not everybody, of course, participates, and I think it was raised in the very first discussion that it's important to understand the characteristics of those that are participating, not participating. So this is something that we were able to adjust based on the information that was available to us for non-response. And then, of course, from a data disaggregation perspective, there was a range of power. We had a fairly large sample size across Canada. I should say that the way that the survey was designed was to produce provincial level estimates. So all 10 provinces had roughly the same power, and really enabled the ability to look at smaller domains as well. And then, of course, the information that was either collected on the questionnaire in terms of self-reported information, but also brought in from other data sources really allowed that disaggregation as well. And I would say that another key component is on the measurement side. So there's obviously going to be uncertainty associated with the sampling that you do, uncertainty associated with who may or may not participate, but you're also going to have some uncertainty associated with the measure itself. So this is really where our partnership with CITF, with the Public Health Agency of Canada, but also our reference labs, was really critical in assessing the quality of the data that we were getting. We performed 2 cross-validation studies between the 2 reference labs that we had for the DBS testing, both before and after collection. And we did a whole range of data quality analyses in partnership with our colleagues there to understand the quality of what we're getting back, comparing it against what was self-reported on the questionnaire, but also looking at other data sources as well. So this is an area that we continue to look at how we could enhance for the future. As I mentioned, the survey was designed with a very specific coverage in mind, but of course it could be adapted to look at a broader geographic coverage. So for example, going into the territories and looking at the population that's in scope. So this was a survey, as I mentioned, was restricted to those that were 18 plus in private dwellings. So it could be expanded to include children, could look at collective dwellings. For both children in the territories, those were actually populations that were included in the first cycle of the survey, just not the second. And then I would say a key thing was this was designed to be a fairly large survey dedicated to long-term symptoms of COVID-19. I think if we were really to rethink this in the context of understanding and monitoring, you would want to design this with a more rapid turnaround of results from the respondent to the lab, more of an ongoing collection, understand how things change over time, and really understand things in a more longitudinal way as well. So this is an area that Statistics Canada and the Public Health Agency of Canada are actually currently collaborating on pandemic preparedness. And that's, part of that process is really a thorough review of what did we learn from our experience with both cycles of CCAS, what are things that we would probably try to build on, and what are some things that we would try to do differently as well. So as mentioned before, you can access that data. It's been released. It's available to researchers through the research data centers. But there's also plenty of products that are available on our website related to this as well. And finally, I'd like to acknowledge again our partners in this space, especially CITF and the Public Health Agency of Canada, but also our reference labs that are listed there as well. Thank you.
Thank you very much, Scott. So I'll go ahead and open it up to questions from the floor, and I can go ahead and ask the first question as people are thinking or coming to the mic, and feel free to ask questions online. I don't think we've had too many throughout the last couple of days online, but you're welcome to ask questions. So one question I had would be, so when it comes to representativeness, there's getting people who are not represented in the study, but there's also better characterizing who is the population in our current study. So when it comes to residual blood surveillance, and maybe Deb, if you want to address this, do you think it's more important to go out and find people who aren't currently captured, or to better understand the characteristics and who is and isn't in these cohorts that we already have access to through like the antenatal or other residual blood programs?
Well, I think if we're going to do sort of timely responsiveness, as we tried to do in the pandemic, I think using assets that are in existence is going to be a lot faster. I mean, it really does take a long time to set up cohorts that are actually recruiting volunteers or patients or whatever. But I agree with you that you do need to understand those samples that you're utilizing. So what are the characteristics of women who give blood for pregnancy, people who go for blood donation, and so on. And then I think ideally, what we would do is take all of these different established assets and put the puzzle together. We have some children's cohorts, we have long-term care cohorts, we have adult mobile individuals of different types. You know, CBS tends to be of one characteristic, antenatal samples or another. But if you put all of those together, I think you can get a really quite comprehensive picture of the population. It's not relying on one set of assets. That would be my thoughts.
Any thoughts from Don or Scott on that? All right, well, we do have questions in the room, so Steve, do you want to go ahead?
Yeah, my question is to Don. You were showing the waning antinucleocapsid in long-term care facilities or older adults. What assay were you using to show the waning anti-N? Because some assays do vary in that. And that was total anti-N as well?
We did anti-N, IgG, and IgA, but it was total anti-N. And ours was a research use only assay that we developed in-house by doing 200 pre-pandemic serum and then doing a series of people with confirmed infections. So I think it would be very, very valuable. I was really inspired by one of the talks on the first day comparing the Abbott and the Roche assays about how one was really useful for reinfection. So all the data I showed you was people's first infection and waning after first infection. And we do see a bit of an extension, and we do definitely see some jumps of people who are reinfected. So I think it would be really fascinating to compare those two and get a sense of whether they would be useful in this population.
And was that a plate-based assay or a bead-based system?
Plate-based.
Okay, thanks.
Tim, go ahead.
Yeah, I just follow up on Steve. I mean, I think interesting, and it points perhaps, Don, to the first point that Alton was making about assay variability between studies perhaps being a bigger issue in comparability than some of the other representativeness criteria that were discussed across the studies. But one question I have related to sort of the network moving forward is that antenatal surveillance gives us great representation across people who become pregnant between the ages of, say, 15 and 50, and things because of the nature of antenatal surveillance. And population household surveys get to most places across 10 provinces, not any of the territories. And there's some challenges related to remote and rural populations and non-reservation populations, as I recall. But we haven't really looked at the representativeness issues related to long-term care homes in any of those. Blood services don't normally get to long-term care residents. And so I'm just wondering, given our notoriety on the worst performance in long-term care, Don, what would be your suggestions on making sure that we continue to have some sort of sense of what's going on in those settings in a way that could fit in with a network on serosurveillance so that we're not missing that important part of the population?
So I will just sort of expand on how non-representative our population is. Ours was, I think, as good as one could get, but there are other things, like, for example, in Ontario, some of the Indigenous run homes didn't want to participate in the study. So that would be a care population that's not affected. And then the homes that were the best set up were the not-for-profit homes that had a history of research. So they had this. And one of the challenges is traditionally our models for doing research in these sorts of populations are we hire a research coordinator, maybe someone from McMaster who goes in and takes blood, and that would completely have failed had we done that. So having the task force funding allowed us to train the people who are already in the homes and the caregivers. And that increased recruitment to really exponential levels because they knew the patients and the participants. And also allowed they were allowed to be in the homes because they were the people working in the homes during outbreaks and things like that. So I think one of the things that we have to think about is investing in a research network of trained people within these homes to deal with the special needs of these people. And, you know, it is my great sadness that we have built this incredible network that could do any vaccine, could do any infection, could do pandemic preparedness, could do measles waning, could do anything. And it's now over. And so I think as we will have to rebuild this during the next pandemic, let us remember that the secret is making sure you're hiring the people within and that you're reaching out and providing extra support to homes that don't already have infrastructure to get some of the homes that are less well off and smaller homes that are sort of publicly run and have, in our experience, really high outbreak levels.
I'll just add that the outpatient laboratory residual blood program, I think, is probably getting a lot of these people. And it would be good for us to be able to assess the extent to which they are or not. And I do think that there are administrative data at the province level on, you know, who is in these homes. But that data linkage needs to happen so that we can assess the extent to which these other modalities like outpatient residual blood are capturing those populations. And kind of do more focused analyses on groups like people living long-term care or older Canadians, where we have these real concerns about health disparities and outcomes that might be different than the rest of the population. All right, so I'll turn it over to Kate.
Yeah, just on that last little note, just older community living Canadians are not being captured antenatally. They're not being captured in the long-term care homes. They're not donating blood if they're over 60, I assume. So we need to think about how we can reach out to them too. My question is for Scott, because I saw on your slide that you were talking about that StatCan and FAC were doing an analysis of lessons learned. And I thought, it just struck me as so strange because the Secretariat worked from co-design through the conduct, through the analysis, to the knowledge translation, to dissemination of results. And I think it would be useful if we could be a partner in that assessment, not because HEMANET's considering household-based surveys, but there are lessons to be learned, and we want to do complementary work to whatever it is that StatCan does do going forward. So it's just a plea to engage and involve us.
Yeah, absolutely, Kate. And just to kind of reiterate, I mean, the first cycle of, just to go back to a point like Tim made, the first cycle did go to the territories. It kind of comes down to how you design the survey in terms of what your coverage is going to be. And I would say that that is one of the advantages, just to Kate's last or previous point there, one of the advantages of going to the private households is you are going to get older Canadians that may not be getting picked up in some of those other sources. Thanks.
Thanks. Go ahead.
Great, thanks, everyone. Just to circle back again to the long-term care piece, is this a perfect example of the need to partner parallelly with groups that can carry out intentional sampling beyond that which could cover the surveillance network through the residual bloods. So, you know, I totally get what you're saying, Dawn, you know, and it speaks to your sample set is as representative is only limited by what is taken up, right? So unless you have missions that allow you to broker relationships with the underserved, with the homes led by Indigenous peoples and so on, unless you lead with that intention to make sure there is representativeness, then there won't be. So there are many of us who can do this, and it doesn't necessarily have to be something that the whole of HEMANET needs to be responsible for if already the catchment doesn't cover those areas. So just seconding your call out to make sure like there are established researchers who have great long-term care webs of research, and so we probably work with Amy Hsu, who works with us, of course, in the biobank. So all together, I think those other barriers that you mentioned can be overcome by this, collaborative effort between the researchers and HEMANET. Thanks.
Go ahead. Yes.
I also wanted to mention that, I mean, I think the very old and the very young, they both suffer from the same sort of access problems. You know, there is a significant proportion of the population in diapers, so they don't end up sampled through the wastewater system. You know, there is difficulties with actually getting, you know, not only do they not contribute as many blood samples, but, you know, even if you want to do dedicated collections, there is difficulties with access. And, you know, we were very fortunate that we were able to actually do some long-term care facility serosurveillance in BC based on the request from public health. But it was exceedingly difficult to get phlebotomists who were comfortable enough to go and collect samples from elderly people with, you know, like often fragile veins, and you know, it is difficult. So I think maybe what we also can focus on as a collective is to try and optimize the use of alternative sample types in both the very old and the very young, you know, blood spots, saliva, you know, whatever other samples we can think of, and making sure that from the outset, if we do need to have, you know, really wide catchment of the population, we are able to cross-validate the different sample types to, you know, be able to provide it seems some sort of, you know, correlates of performance to people who analyze the data.
And can I just make a comment on that? So it sounds like dried blood spots would be easier in this population. And for a while, we were collecting them because we wanted to sort of standardize with all the other groups. Actually, the older adults in long-term care hated dry blood spots. So we ended up actually changing our protocol to do a venous blood draw and then physically drop the blood on the dry blood spot cards, because they had no issues with giving blood, but they absolutely would never do another dried blood spot again. We also tried to implement a saliva collection around the 4th doses, and we found that that was incredibly hard to implement. You know, there are people who have swallowing issues and choking issues, and so we ended up learning that that was okay in the retirement home side, but in the long-term care home, it didn't work. So, so again, these are just learnings I share with you, so you can bring them to your own learnings. Dry blood spots are a one-time only deal in my experience, because they'll never consent to doing them again.
Very interesting. Lori, maybe for the last question.
Actually, just a brief comment, or maybe if you have experience with this response to it. As we seek more and better representativeness across populations, and we get into some very small populations, certainly one thing that we know from genetics is that once you get into a smaller population, de-identification can start to become a little bit of a challenge. So I just wanted to put the call back out to say, I think communicating with the populations that we're trying to reach and that we're trying to serve has been a common theme. And so just a call for engaging some of these populations. In our hands, for example, we did not collect certain data because we hadn't had the opportunity to do that engagement with a people group who may not have responded well to it just being sprung on them. So engagement.
Thank you. Important point. Any final thoughts from our panelists? No, I think I'll make one, which is I think that we characterizing the population more timely, being able to understand, I think there's a lot of value that was left on the table because we weren't able to quickly look at issues of health equity because the data were not linked and available to people with the skills to analyze them. So I think representation goes beyond who's in the study, but how much we know about them, and are we getting those data to people who can analyze it. So let's thank all of our panelists one more time.